Hi, I'm Dr. Jamie Catlow, one of the gastroenterology registrars in the Northern region. As a region, we've had a few serious events where patients have been fed with NG tubes in the wrong position, leading to patient harm. These events can be prevented through basic safety checks before starting feeding. Each trust you'll work in will have different exact guidance, however, are based on the above algorithm from the National Patient Safety Agency. The first question to ask is this the right decision for your patient? Think about patients with high risks of complications, like those in a coma, those with severe vomiting, retching or swallowing problems, or with anatomical problems of the esophagus. The decision-making process assessing these risks involving the patient and their senior doctor should be documented in the patient notes. The second question you should ask is now the best time to be inserting an NG tube, and is all the equipment available? The National Patient Safety Organisation was concerned at the number of errors because of position confirmation out of hours. If it's the middle of the night and the indication isn't clinically urgent, delay placement until the day team support is available. The equipment you'll need includes a radio-opaque NG tube, lubricant, an enteral syringe, a fixation dressing, water if the patient is able to swallow, and pH testing sticks. Measure the length of the tube from ear to nose to xiphisternum. Here it's 48 centimeters. Ask the patient to blow out of each nostril to see which is most patent. If in doubt, use the right. Insert the NG smoothly, aiming posteriorly and not superiorly. Warn the patient they may feel a gagging sensation, usually at 10 to 13 centimeters. If able, ask the patient to swallow some water. Insert to the pre-measured length, then fix the NG tube using the adhesive dressing. Note the tube type and the distance at the fixed dressing in the notes. The third question to ask is, does someone have the expertise to do a successful pH and chest X-ray check of the NG tube's position? Position of the NG should be checked after initial insertion or when you suspect the tube has been displaced. It should also be rechecked after significant episodes of vomiting, retching, coughing, or if there are new respiratory symptoms or a fall in the oxygen saturations. The first check is to aspirate from the NG and check the pH. Sometimes you will be unable to get an aspirate. The first step is to inject 10 to 20 mL of air down the NG tube and then reposition the patient, usually onto their left-hand side, and try again in 15 minutes. Do not use water to flush the NG before position is confirmed. The National Patient Safety Agency recommends an aspirate with a pH of less than 5.5 confirms correct placement, however local guidelines may vary. If the aspirate does not reach this threshold, then proceed to a chest X-ray. So how do you confirm an NG on a chest X-ray? Firstly, on this normal chest X-ray, we need to identify the carina, the Mercedes shape highlighted in blue where the bronchi leave the trachea, and the diaphragm in purple. Now on this chest X-ray, we have a radio-opaque NG tube. To be safe for feeding, you must be able to demonstrate three things on the chest X-ray. Firstly, the NG tube in green bisects the carina and does not follow a bronchus. Secondly, it crosses the diaphragm near the midline. And thirdly, the tip of the NG is below the diaphragm. Once again, this tube is safe for feeding as the NG bisects the carina, crosses the diaphragm at the midline, and the tip is below the diaphragm. If you'd like some more practice looking at NG tubes on chest X-rays, then I would recommend the free radiology masterclass on NG tubes, demonstrating correct and incorrect NG positions. The key messages are to ask, is this the right decision for your patient? Is now the best time to be inserting an NG tube? And is someone available with the expertise to check the pH and interpret a chest X-ray successfully?
It's ripped.
It's all your fault.
Take off. Take off.
This is awful.